Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, let me just welcome a very renowned doctor, Dr. Anil Ganju. Sir is MBBS MD Dermatology, Venerology and Laparoscopy, Director of Skinovision Clinic, the World of Aesthetic, Model Town, New Delhi. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is managing seborrheic dermatitis, a practical guide for clinicians. Now, without any further delay, let me just welcome Sir again at our forum and hand over the session to him. Over to you, Sir.
Thank you, Shreyan. It's a pleasure indeed, and I really like to get back to IJCP for their academic activities, because I do remember Dr. Agarwal, who was the founder of all these academic activities. Really appreciate his efforts and still continuing. And congratulations to you guys to be keeping on the good work. So with this, we start the presentation for the day. We are talking about a common condition amongst both infants and adults called seborrheic dermatitis. I'm going to talk about some practical points about this condition and where the general physicians can take care of this and where they need to, refer to a dermatologist. Now, seborrheic dermatitis is a chronic inflammatory condition of the skin. It happens in the areas, the so-called seborrheic areas of the body, basically the ones where there are a lot of sebaceous glands, like the scalp, the face, the body folds, and it has two variants. One variant is the one that happens in the infantile age, so within the first year of life, and is known as infantile seborrheic dermatitis. And the other one, the adult seborrheic dermatitis, usually happens after adolescence and usually in mid-adult age. Now, the infantile seborrheic dermatitis, although is short-lived, but can extensively involve the scalp, the face, the flexures. In the scalp, it appears as firm, greasy scales over the frontal regions of the scalp. And although it doesn't bother the child too much, the parents are really bothered, and there's a lot of parental anxiety associated. Usually starts early in life. Within the first 3 months of life, the child who has to get infantile seborrheic dermatitis has it, but it's a self-limiting condition. And within the first year or year and a half of life, the condition goes off, and it basically is because of the influence of the maternal hormones that are passed into the child, and they are stimulating the the sebaceous glands into activity and inflammation, and leading to the infantile seborrheic dermatitis. The adult seborrheic dermatitis, on the other hand, is a more chronic, relapsing, and remitting condition, and is quite common, can have a huge impact on the quality of life. In fact, has been ranked only just behind atopic dermatitis and contact dermatitis as far as the effect on the quality of life is concerned. The prevalence is quite high. About 5% of the patients worldwide have proper seborrheic dermatitis, but the non-inflammatory variant, that is the dandruff as you call it, which is associated with scaliness of the scalp, happens in much more number of patients, about 50% prevalence across the globe. All ethnic groups are affected globally. And the infantile variety happens, as I told you, within the first 3 months of life, and usually ends by 1.5 years of life. And the second peak happens in the 4th decade, where we call it as the adult seborrheic dermatitis. A study in the Australian preschool children showed that the prevalence of seborrheic dermatitis was to the tune of 72% in the infantile phase, and later on it fell down to about 10%, and in the middle aged about 14%. And patients who have an immunocompromise, particularly like patients who have HIV and AIDS, can have very high incidence of seborrheic dermatitis to the tune of about 35% in patients of HIV infection, and up to 85% of patients who have full-blown AIDS. There are multiple factors that are associated with the development of this disease, and the pathogenesis is very complex. And there's an interplay between the normal microscopic skin flora, like the yeast called Malassezia furfur, and the composition of the lipids in the skin surface, the quality of the sebum, the fatty acids that it contains, and the breakdown of those fatty acids by microorganisms like Malassezia furfur are the factors that determine the kind of inflammation that will happen in the skin. The level of sebum, that amount of sebum may not be important. The quality of sebum is probably important, and the ability of the yeast to break down these sebaceous gland, sebum contents, leading to inflammatory mediators, is more important than the amount of sebum produced. Now, the risk factors, as I told you, the age, infancy, and middle age. Males are affected more oftenly. If there is an increased sebaceous activity, definitely seborrheic dermatitis is more, but that's not the only factor. The quality of sebum is also important. And if there is immunodeficiency, the incidence of this disease goes up considerably, like in patients of lymphoma, those of renal transplant on immunosuppressives, patients of HIV and AIDS, etc. Neurological and psychiatric disorders are also associated with a higher incidence, like patients of Parkinson's, stroke, Alzheimer, depression, autonomic dysfunction. All these patients will have a higher incidence of the disease. Certain drugs like dopamine antagonists, immunosuppressants, lithium, which is given for depression, low humidity and temperature in the atmosphere, all these are risk factors, can be associated with a higher incidence. Now, as I told you, pathogenesis is complex. It's a complex interplay between those who are predisposed and produce a specific kind and quantity of sebum, those who have an impaired immune response to the microflora of the skin, like the Malassezia species, the diminished cell-mediated response, and different kind of an activation of the complement cascade, those who have an increased amount of unsaturated fatty acids in the sebum and the skin surface. So all of them have a greater possibility of developing this disease. Now, there is disruption of cutaneous neurotransmitters, there is abnormal shedding of keratinocytes, there is a disturbed epidermal barrier also. So all these factors contribute to the development of the disease. The Malassezia furfur is central in the development of this condition. It one leads to disintegration of the saturated fatty acids within the sebum, disrupting the lipid balance. It also leads to disturbance in the skin barrier, and its involvement in the development of this condition is proven by the fact that, one, it can be easily isolated in high quantities in patients in the skin lesions of seborrheic dermatitis, and also isolated antifungal treatment leads to improvement of this condition to a large extent. Now, clinically, in the infantile stage, the disease presents within the first 4 to 6 months of life, and usually as a rash on the so-called seborrheic areas, the cheeks, the flexures, and the forehead, the retroauricular area, and the scalp. In the scalp, we have these greasy, thick, adherent scales that produces serous discharge and a greasy crust that can be firm at times and difficult to remove from the scalp. And this is it has to be differentiated from a condition called Pityriasis amentation, which can be a very thick adherent mass of scales attached to the surface of the scalp, which happens in patients, one, seborrheic dermatitis, but also patients of atopic dermatitis, psoriasis, etc. But patients of psoriasis can be differentiated by presence of nail changes, by presence of itching, by presence of other lesions on elbows and knees that can show that is psoriasis. Tinea capitis can be proven by isolating the dermatophyte from the scales or the hair in the area. Atopic dermatitis can be differentiated by it being severely itchy. In the adult phase, it affects primarily the face, the scalp, and the chest in percentages like 88, 70, 27% approximately, respectively. On the head and the neck, it presents as a symmetrical rash involving particularly the central third of the face, including the malar region, the central forehead, the eyebrows, the retroauricular area, and the external ear canal. Characteristically, the nasolabial folds and the alar folds are affected. There can sometimes be involvement of the eyelids and the eyelashes, blepharitis. This is a common association. It's important to differentiate it from psoriasis, as I've already told you, where you have more indurated and inflammatory red plaques. There will be less greasiness in the scales, more dryness and silvery scales. There will be psoriatic nail changes. The auspice sign is positive, which means that if you scratch at the scales, there is easy bleeding underneath. And sometimes there can be an overlap of psoriasis and seborrheic dermatitis, which is known as sevopsoriasis. And you don't need to really investigate routinely these patients, but as I told you, sometimes if somebody has a very severe disease, they can be associated with immunocompromise. Then look for causes of immunocompromise, do an HIV serology, look for neurological disorders like Parkinsonism, etc. These tests can help you distinguish from other conditions, like a KOH examination to exclude a fungal infection, histology and direct immunofluorescence to look for differentiate psoriasis, do an HIV serology if there is very severe disease, do serum zinc levels, because zinc deficiency can present like this, anti-nuclear antibodies, etc. The approach to the treatment and management of seborrheic dermatitis is primarily first to discuss a good general skin practice and tell them to use a proper shampoo to keep their scalp clean, to keep their face clean. They need to moisturize their skin well, because although it looks greasy, but actually the barrier is disturbed. The moisturization is important. I'm sorry. Am I connected? Am I connected, Shreyan?
Yes, sir, you are connected.
Okay. Sorry, there was a call in between. I thought I got disconnected. Anyway, good shampoos that will help you remove the hyperkeratotic scale from the surface. If you suspect a secondary infection, treat with antibiotics. Also, if there is itching, then give antipruritics. Uh, a Danish expert group recommended that the first line should just be topical antifungals. I told you antifungals can give you a lot of relief, and try to reserve steroids, calcineurin inhibitors, etc., for patients who have more symptoms and severe disease or flare-ups. Typically, the treatment module includes antifungals, one, topical, and sometimes oral also. If there is severe disease, you give antipruritics, and then anti-inflammatories. You can give topical steroids and calcineurin inhibitors. Primarily, when a patient of seborrheic dermatitis comes to me, he will get an antifungal ketoconazole shampoo with or without tar, sometimes with salicylic acid. The tar and salicylic acid act as keratolytics and keratoplastics and remove the scale. The ketoconazole acts as an antifungal to take care of malassezia furfur. We also give them local steroid antifungal combinations, lotions, initially to take care of the infection and inflammation. We give them moisturizers for the face, and for the face also we can give them a mild steroid and an antifungal combination. Once the disease is under control, then the patient is maintained on only a shampoo and a moisturizer. And if there is any recurrence of the disease, then you may give a topical steroid or a calcineurin inhibitor for some time to take care of the inflammation. The shampoos will typically contain ketoconazole, salicylic acid, tar. These are all basically keratolytics, antifungals, anti-inflammatories, etc. The shampoo should preferably be applied into the scalp and kept for at least 5 to 10 minutes before it is washed out. Topical ketoconazole has been shown to be safe in infants, useful. One has to be careful about using corticosteroids. Usually the mildest corticosteroids, the class 7 or 8, not very strong steroids. You treating seborrheic dermatitis, you should know classes of steroids. For example, a clobetasol would be the class 1 steroid avoided. Would be a mild class 1 2 steroid. And once the infection is brought, you may go to acrolein to take care of the condition. Oral treatment is severe disease, but patients who have severe disease need oral antifungals and antipyretics. Generally, we can use oral, but we have to be careful about the drug interactions. This is also can be given, but you have to be careful about the drug interactions and renal function, hepatic function. Sometimes we use low dose isotretinoin for adult variety because that reduces the sebaceous activity and
Uh, because of some network issue, sir got disconnected. He will be joining soon. So I will request everyone to please stay tuned.
समझिए अब हम कहाँ जाएं आपका चलता ही नहीं आ रही है
Sir, am I audible?
Yeah, you are audible. I had a
Yes, sir.
problem with my. I'll
Yeah,
change my
yes,
place.
you got
Okay.
disconnected.
Okay, now I have to share the presentation again.
Yes, you can share the
I have to
screen
share the
because,
presentation again, no?
yes, yes, please.
Is it there?
No, sir, not yet.
Getting uploaded.
Yes, it is here now.
हो रहा है.
It is done, sir.
Yeah.
Just check. Yeah.
So yeah, just I'm going ahead with the management. Where were you? What's happening? प्रेजेंटेशन आगे नहीं जा रही. हाँ जा रही है. There's some problem. Are you also fiddling with it? I think you don't do it. Are you doing something about it?
No, 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 sir. I'm doing nothing about it. I'm not controlling anything.
आप छोड़ दीजिए please.
Sir, I'm not controlling the slides. I've done nothing. Am I audible? Hello?
आगे. हाँ, you're audible. It is not going ahead actually. I
Sir, I'm not
me
controlling the slides.
Shreyan, can you hear?
Sir, there's
But I
a
don't know what's
lot of
happening
network
there.
issue.
They are just,
A lot. Actually, your video is not moving at all.
my presentation is also not moving. Okay. Okay, I think we are where we were. Okay, friends, sorry about this glitch. I told you about the shampoos. It has jumped again. It is jumping on its own. Okay. So I told you about the shampoos. They typically will contain coal tar, they'll contain salicylic acid, it will contain anti-inflammatories and antibacterials. And I told you you need to apply it for 5 to 10 minutes before washing it off. That will give you the best effect. And topical ketoconazole we have already talked about. We have talked about the side effects. We have talked about the oral agents. There's a lot of jumping happening around. So future therapies of seborrheic dermatitis are being looked at, which would improve the skin barrier function and restore the skin surface's lipid composition. The prognosis, as far as the infantile seborrheic dermatitis is concerned, I told you that it's a self-limiting condition, and usually within the first year or maybe maximum 2 years of life, the disease will be gone. But the problem is with the adult variety of seborrheic dermatitis, where the disease is chronic, is associated with remissions and relapses, and can have a huge impact on the quality of life. And it is only controllable but not curable. You have to counsel your patients that once the condition is brought under control, it is to be maintained with proper shampoos, etc. Complications, there can be secondary infections with bacteria, or there can be secondary infection with candida. So many a time we need to give them oral itraconazole, etc. The involvement of the whole body surface area with the condition known as erythroderma is very, very uncommon, but has been seen particularly in the infantile variety. So once it happens, you have to look for more serious causes of extensive seborrheic dermatitis like HIV and AIDS. However, this is a very uncommon situation. The management pearls consider the impact of seborrheic dermatitis on the psychological, psychosocial functioning and quality of life of the patient. It can sometimes accompany neurological and psychiatric disorders. Therefore, you should be always open to the possibility of assessing the patient for psychiatric disease. The dermatologist can be helpful in guiding the patient and the physicians with the proper use of topical corticosteroids. We talked about the classes of corticosteroids that are available. You can have a strongest of the steroid, you can have a mildest of the steroid. So generally, we resort to mildest of the steroids, and once we have brought the disease under control, we come to steroid sparing agents like calcineurin inhibitors, tacrolimus or pimecrolimus. Diet is important, so counsel them to take a healthy diet which is low on junk and high fruit, high vegetable, high green diet is associated with a 25% lower risk of seborrheic dermatitis, and western diets can be associated with up to 25% increase in the risk of seborrheic dermatitis. So proper diet consultation is also very important. Therefore, friends, seborrheic dermatitis may look simple but can be complex sometimes. And although you as physicians you guys help to understand the exact nature of the steroids and try and help you to you to prescribe them judiciously so that minimum side effects happen because of topical corticosteroids. And remember that infantile seborrheic dermatitis is a self-limiting condition, so you need not be very aggressive. Just give mild topicals only for to the child to tide over the situation. It's only the adult seborrheic dermatitis which needs to be treated more aggressively and then counseled, and the patient needs to be put on proper maintenance to avoid relapses. Thank you very much for your kind attention. Very sorry about the glitches that happened, and I'm open to a few questions. Shreyan, if you're there. I can't see you though. Shreyan, can you hear me? Are you there, Shreyan? Are you there, Shreyan?
Hello. Sir, am I audible?
Shreyan?
Yes, sir. Am I audible?
Yes, I can hear you. I can hear you.
Yeah.
Yes.
So I think we got disconnected because of the network issue, sir. So we do have some question after the presentation of yours.
Yes, please.
Yeah. So the first question is, how can clinician differentiate uh, the seborrheic dermatitis from cirrhosis? Yes, from cirrhosis and fungal infection.
Can you repeat it, please?
Sure, sir. The question was, how can clinician differentiate seborrheic dermatitis from cirrhosis and fungal infections?
Be differentiated from seborrheic dermatitis?
Yes, sir. Seborrheic dermatitis, cirrhosis, and fungal infection. How can we differentiate it?
तुम लोग फोड़ो इसे। मैंने 10 बार बोला तुम लोगों को ये। What is this nonsense? चलो ऊपर यहाँ से।
Shreyan, sorry, yes, tell, please repeat your question.
Sure, sir. Yes, the question was how can clinician differentiate seborrheic dermatitis from cirrhosis and other fungal infections?
You see, during my presentation, I had made a mention of this, that you need to differentiate these two things. Psoriasis typically presents as thickened plaques. It would not be just scales. It would be redness, plaques. There would be itching associated with it. Then there are associated changes like in the nails, we have pitting. We have involvement of the elbows, we have involvement of the knees. So all that put together, and the scales are less greasy. You can easily scrape off the scales and you will see bleeders coming underneath. That shows that you're facing psoriasis. Fungal infections can be differentiated by doing a fungal scraping, a KOH mount, which will help you differentiate and pick up dermatophytes that are the cause of fungal infections. So yes, you have to keep your eyes open to the possibility of these conditions before you make a diagnosis of seborrheic dermatitis, although it's very straightforward. But sometimes, yes, it becomes difficult because those conditions also happen in the same areas.
Thank you, sir. There is another question. What are the key consideration for managing seborrheic dermatitis on the scalp versus the face and body?
See, scalp will have all these scales and greasiness, and scalp will need a shampoo. Shampoos generally containing antifungals like ketoconazole, zinc pyrithione, and agents like salicylic acid, which are keratolytics, tar, which are keratolytics and keratoplastics, and sometimes even topical anti-inflammatories like steroids. So, scalp will require shampoos like that, and the skin lesions will require moisturizers and usually a mild steroid and an antifungal to start with, later on just a moisturizer.
Thank you, sir. There's one last question. How does seborrheic dermatitis present in infant, and what are the recommended treatment approaches?
See, in infants, it usually happens because of the transfer of the maternal hormones into the into the infant, and usually it presents by the age of about maybe 3 months, 4 months, and is self-limiting. That's a very important thing that people have to remember. It's a self-limiting condition, does not last for more than a year, year and a half. By the time the maternal hormones are washed out from the child's body, it usually presents as greasy scales on the scalp, and in addition to that, there will be inflammation in the scalp, around the eyes, on the face, in the flexures, like in the neck, in the diaper area. All these areas will be inflamed and have greasy scales. So but then it is a self-limiting condition. As the child grows, becomes a year or year and a half old, that's it, the disease is gone. But in adult variety, it will be a chronic disease that will come again and again.
Thank you, sir. That's all from our audience, and thank you for answering all our questions. So,
Thank you, Shane.
before
Sorry for the glitch.
concluding,
Yeah,
sorry, sir, you're saying something. Please
I
continue.
was asking for your forgiveness for the glitches that happened. There was some
No, no,
issue.
sir, that's totally understandable. We can understand, sir. So, sir, before concluding, any take-home message, sir, for our audience?
The two most important things: one, in the infants, it's a very mild self-limiting condition. Unless it's very severe, you have to ally the parental concerns only and tell them that's a self-limiting condition, is going to end on its own, so you don't need to be very aggressive in children. But in adults, yes, you need to counsel your patients that this is a chronic condition. Even if you have treated it, it's going to come and go and come and go. So counseling is important. They need to understand that it's a chronic disease, and once you have brought the disease under control, you may need to continue maintenance treatment for a long time.
Thank you, sir. Thank you so much for sharing your wonderful insight with us, and thank you for joining our session. Thank you.
Thank you.